Shock differentiation made easy. A shocking NCLEX question about shock. Your patient is hypotensive with a systolic in the 80s and tachycardia with a heart rate in the 120s at rest. The lactate has been rising, but you just began an antibiotic the patient has never been exposed to before. And, is that wheezing you hear? Is the patient experiencing worsening septic shock, or new anaphylactic shock? First, what are the symptoms of each? Septic shock usually grows out of infection and might present with fever, elevated lactate, altered mental status, warm and reddened skin, and worsening perfusion. Anaphylactic shock tends to hit fast after an exposure, usually immediately after exposure to an allergen. Anaphylaxis involves adventitious lung sounds like wheezing or stridor, facial swelling, hives, and hypotension. Your patient just received a new antibiotic, and antibiotics are famous for causing allergic reactions. Due to the recent administration of a new med, get your rapid response called while you work to support your patient's breathing with oxygen support and managing their anxiety, protecting their airway. You won't be giving fluids at first in anaphylaxis like you do in septic. You give a pressor. In the field, it's an EpiPen. At your job, it's called epinephrine to rapidly reduce swelling and possible airway collapse. Anaphylaxis is an allergy gone haywire needing airway support and epi. Septic shock might also need epinephrine, but it's not the first drug used to support blood pressure. Sepsis begins with fluids and cultures, and maybe vasopressors for BP, beginning with levofed, or norepinephrine. Yup, epinephrine and norepinephrine are related but they are different drugs given for different reasons. Don't memorize shock, learn the types of shocks and how you can tell them apart and how to treat them separately. And forget your ABCs, keep the airway open and before anything else. Keep it up. Yes. You can. Subscribe and study with us.